Let us revise poliomyelitis for you. Poliomyelitis is caused by three viruses, Lyon, Lansing and Brunhilde. They are enteroviruses, means that they grow in the intestine and spread by the fecal-oral route. And they are cultured on monkey kidney tissue culture and chick embryo. Now these viruses enter through the fecal-oral route, fecal-oral contamination, and because of the fecal-oral contamination they first grow in the intestine. So they first grow in the intestinal mucosa, then they go into the bloodstream, then they go into the antion cell. In the antion cell, the changes are that the dendrites are withdrawn, the cell becomes rounded, the nucleus becomes pycnotic and eccentric, and the granules disappear. And there is a sort of a cloudy haze in the cytoplasm. Now these cells around the blood vessels in the spinal cord there is lymphocytes all around, which is called as perivascular cuffing. Then in the glial tissue there is a lot of edema. So this is the histology of changes in the spinal cord. Therefore, after understanding this pathology, you would be very easily able to understand the stages of poliomyelitis. The first is infection. The second is incubation. Third is a pre-paralytic phase characterized by diarrhea, enteritis, and influenza-like sickness. This means the virus is in the bloodstream. And this influenza-like sickness has got two very important characteristics. One, there is acute muscle tenderness. And the second very important thing is that if you give injections or traumatize it, the likelihood of the paralysis of that muscle increases. Right? So post-trauma paralysis. Paralysis probability will increase. These two facts were recognized by an Australian nurse who was called as Sister Canny, and therefore she said no injections, no trauma, and hot saline fomentation. So this treatment, this combination of treatment is called as Sister Canny's treatment in honor of her name. Right? Then you come to the paralytic phase. In the paralytic phase, there is a pre-paralytic, a phase of increasing paralysis, phase of decreasing paralysis, phase of residual paralysis. Then increasing, decreasing, residual. This point is recognized by the fact that acute muscle tenderness becomes absent. You will, in this particular phase, there can be bulbar polio, which can lead to cranial nerve palsy and also respiratory paralysis. Therefore, in this phase of polio, an intensive care unit is the best place that a person can be. Nothing else, steroid, etc., nothing else. But this particular phase, after acute muscle tenderness is absent, you must maintain tone of muscles, and that the sequence is galvanic, Faradic, active assisted, active resistant, and you must maintain functional position, and that you do with a long Liston splint, maintaining hip and knee in neutral position with a foot piece. So here is the thigh, here is the thigh, here is the knee, here is the foot. So this long Liston splint with foot piece is the method to ensure that there will be no contractures. You will get the cases in the residual phase, and in the residual phase you have to understand that the patient will usually present with deformity, power loss, and shortness. There will be history of fever, paralysis, which is motor, which shows increasing, decreasing in residual phase, and which there may be history of acute muscle tenderness. I have forgotten diarrhea, but diarrhea can be one of the features. In this phase, if the patient comes to you, if you do a stool culture on MKTC or chick embryo, you may get the poliovirus. Now, what are the deformities? Flexion, abduction, external rotation, which means cross-legged sitting position, which is called as Taylor's deformity, because Taylor's legs sit cross-legged. In the knee, flexion, posterior subluxation. In the foot, on ankle, equinus, calcaneus. On the subtaloid joint, inversion, eversion. On the mid-tarsal joint, cavus, planus. In the toes, cocking of great toe, clawing of the great toe, clawing of the great toe. It's not really clawing, it is called as hammer toe, which is for the first, and clawing for the rest. Right? So these are the deformities that you encounter, and they are prevented by in this manner. So how do you manage the deformities? The first thing is stretching, physiotherapy, corrective plaster, orthotic devices. That is the first stage. That is conservative. You must always do a conservative treatment because that decreases the degree of surgery needed for correction of the deformity. The second step is soft tissue. The soft tissue areas around the hip are two. One is called as sutures, other is called as cambers. पानी दे पानी Sutures, position of patient supine, patient under anesthesia, generalospinal part preparation and draping done. You give an incision on the anterior 1/3 of the iliac crest, on the external lip, up to the anterior spine, and extend it in the anterolateral line in the thigh, between the sartorius and the tensor fascial artery. So, if this is the anterior spine, this is where the sartorius is going. And here is where the tensor fascial artery is going. So the incision comes on the iliac crest and then extends like this, parallel to the tensor fascial artery, which has become the iliotibial band. Correct? 3 centimeters below the anterior spine, the lateral cutaneous nerve thigh is piercing the sartorius and becoming the lateral cutaneous nerve thigh. It is emerging under the inguinal ligament from here. Correct? And if involved in the inguinal ligament, there is meningia paresthetica. So this is the incision. Then you divide the D fascia. Incision, okay, divide the D fascia, save the nerve, and ligate the circumflex iliac artery. So there is a circumflex iliac artery which has to be ligated here. So ligate circumflex iliac artery. Okay. Then under this you will see a muscle. This is the vastus vastae. So this is the vastus lateralis. And then from the anterior spine, helping this vastus lateralis, from the anterior spine would be arising the straight head of rectus femoris. This will be the reflected head, this will be the straight head, and this muscle that you see here you make it with a different color. This muscle is rectus femoris. So between the vastae on the medial side and the tensor fascia lata, you develop a gap which goes right up to the lateral intermuscular septum. You must understand that if this is the tensor fascia lata, like this, here is the deep fascia, right? Here is the deep fascia. This deep fascia will go and get attached to the linea aspera. So here will be the intermuscular septum. So what you must do, that you must actually cross this intermuscular septum. You should go deep and you should actually pierce this intermuscular septum. So one lip of the Cocker's forceps is here, alright, and the other lip is between the skin. So you see, here will be the skin and subcutaneous tissue. So you have dissected this flap, lower flap, right up to the iliotibial band, so that you can place two Cockers on the tensor fascia lata. And then you divide this tensor fascia lata completely. You understand? जब तक इंटरमस्कुलर सेप्टम नहीं पियर्स करोगे तब तक टेंसर फेशिया लाटा पूरा पकड़ में नहीं है. So you divided this tensor fascia lata. One. The second thing is that you must divide the sartorius. You must divide the deep fascia. You see, the deep fascia is extending from the tensor fascia lata like this. It's going parallel to the inguinal ligament. And here is the saphenous ring and here is the saphenous vein. So you must lift off the anterior flap. You must lift off the deep fascia from the sartorius. You must hold this deep fascia parallel to the inguinal ligament. And you must divide this deep fascia but right up to the deep inguinal ring. So you divided the tensor fascia lata, you have divided the deep fascia. Correct? The third thing you divide is the sartorius and you save the lateral cutaneous nerve of thigh. And the fourth thing is you divide the straight head of rectus femoris. This finishes the tutor's operation. Now, if you want to proceed to Campbell, this is the iliac crest. Okay. On this side are the muscles external to the iliac crest. On this side are the muscles internal to the iliac crest, and these are the anti-abdominal wall. So you erase these, and if this is the growth plate, of the iliac crest, then you remove this much of bone so that the iliac crest becomes short, and this rests here. This epiphysis will come here. When the iliac crest becomes shortened, all these muscles will be automatically released. So this is the Campbell operation. Correct? Then after this Campbell operation, you must restore extensor power to the hip. Because what is the deformity? Flexion, abduction, external rotation. Abductor, external rotation is alright, but you must restore gluteus max. Now this gluteus max will be restored when you remove the sauce from the lesser tuberosity. Alright, make a hole in the ilium, take it back and stitch it to the gluteal tuberosity. So psoas to gluteal tuberosity. This operation goes by the name of thoracotomy. All right, the covered suitures. याद हो गया? Then we go to the knee. In the knee, you understand that this is the femur. This is the lateral intermuscular septum. This is the medial intermuscular septum, right? And this is the deep fascia. This is the deep fascia of this side. Then here is the vastus lateralis. Here is the rectus femoris. Here are the three adductors, adductor longus magnus. This is basilis. This is the medial side. Okay. You see, here is a fascia like this, and here is a canal here which is called as the subsartorial canal, and here will be the sartorius muscle. So here will be sartorius, and this will be subsartorial canal. Alright. So rectus femoris, sartorius, subsartorial canal, adductor longus, previous magnus, basilis. Correct? Here will be the iliotibial band. Here will be the biceps short head, biceps long head. There will be semimembranosa, semimembranosa. Okay? Now, this will be skin and subcutaneous. You make an incision in the skin and subcutaneous tissue above this. Lift off the skin. That means the skin becomes like this from the deep fascia. Lift off the skin like this from this deep fascia. So now you don't have the skin. Now the skin has been lifted off. Okay. And what you see is the deep fascia and the iliotibial. Now you make an incision in the deep fascia here, right? And you make an incision in the deep fascia here, and you hold this iliotibial band right up to the linea aspera in between two cockers, and you divide 3/4 of an inch of 3/4 inch of IT band and lateral intermuscular septum right up to the lateral lip of the linea aspera. Then there is the lateral popliteal nerve here and the posterior tibial nerve. Then you have the artery. Then you have the nerve, artery and vein. Vein is superficial. Okay. So this is the Young's operation. Now extension of Young's operation. Put a Cocker's forceps across this deep fascia, right this. And then you divide this deep fascia. This deep fascia will be divided between the two cockers, right across the thigh. अब deep fascia कट गया, plus deep fascia हो गया, है ना? Then you divide the biceps लॉन्ग एंड शॉर्ट हेड यहाँ पे कंबाइन हो जाए, सेविंग द LPM. Then you divide the semi-membranosus and semi-tendinosus. Then you divide the two heads of the, ये जो तुम्हारे ये गैस्ट्रोक्रीमियस के इस तरह से आते हैं, ये आया लीनिया एस्परा, इससे जो है तुम्हारे गैस्ट्रोक्रीमियस के ये दोनों हेड निकले, इनको डिवाइड करो. देन यू डिवाइड द कैप्सूल सेविंग द लिगामेंट. Divide the capsule saving the ligament, saving the middle genicular artery and saving the posterior cruciate ligament. So you divide the capsule, divide gastrocnemius, both heads, divide capsule, divide, already divided semi-membranosus, semi-tendinosus, biceps femoris, save posterior cruciate ligament and middle genicular artery. Now this damned middle genicular artery plasters the popliteal artery to the posterior capsule, so you can't really see it well, right? So you must really expose it carefully before you do this capsulotomy. Ligate it so that you don't open the popliteal artery carefully, because the problem with the ligation is, आप लोग करोगे क्या कि ये आर्टरी से ये निकल रही है ब्रांच, है ना, तो आप ऐसे भी लाइगेट कर सकते हो. नो, टू लाइगेट दिस, ठीक है. तो मिडिल जेनिकुलर आर्टरी लाइगेट करके कैप्सूल और सेव PCL in this. This is called as Willy brand modification of young. अब इसके अलावा क्या हो सकता है? इसके अलावा जो है ऐसा होता है कि अगर ये फीमोरल कंडाइल है और ये फ्लेक्शन कॉन्ट्रैक्चर है, तो फ्लेक्शन कॉन्ट्रैक्चर सीधा करने में, क्योंकि एंटीरियर क्रूशिएट लिगामेंट बहुत टाइट हो गया है, तो सीधा करने में ये जो क्या करेगा, ये पोस्टीरियरली सबलक्स कर जाएगा. ACL will posteriorly sublux this, so you may have to, by a posteromedial approach, parapatellar posteromedial approach, you may have to divide the ACL to align it. Alternatively, you can give what is called as the Hamilton-Russell traction to correct the posterior subluxation. Then you must correct the deformity without stretching the artery or nerve. This is Jones, and we'll cover the foot next time. Right? Correction of foot deformities and restoration of power around the foot. Here the restoration of power is very simple. You transfer the hamstrings to quadriceps. All four. Alternatively, अगर ये है तो what you can do, you can sort of shorten the hip. So that's it.